I think misophonia, for sure, is the least understood, or that we have the least amount of providers out there able to help patients with misophonia. I feel like they definitely had a spike in misophonia post COVID, and I think
Mm,
that was related to the isolation and not being around each other, and then we got back with each other, and so we had kind of a spike in requests from patients with symptoms similar to misophonia. But um, yeah, it is very complex and takes time to really tether through to understand, is this just a temporary reaction, or is this, like you're saying, a disorder that needs more involved treatment? But have you found for misophonia and hyperacusis that some of the very similar principles from TRT and PTM can help those patients as well as tinnitus patients? So the sound therapy approaches.
yeah, so I think with loudness hyperacusis is pretty straightforward. Sound therapy is the key to treatment for loudness hyperacusis. For misophonia, I know that TRT recommends having the patient listen to sounds that are interesting to engage their mind, get them to used to listening sound. With misophonia, people are generally bothered by body sounds, chewing, smacking your lips, tapping your foot. Different body sounds are
Mhm.
just drive them crazy, almost to the point of rage, and they have to
Mhm.
leave the room when they're sitting at a table with people eating. And I think part of that an audiologist can address by doing a specific sound therapy program, but they may also need psychological counseling for what's at the root of why they react to those specific sounds, and often it's a psychological issue. So I think loudness hyperacusis is more straightforward for an audiologist to treat. Misophonia, an audiologist may be able to treat effectively, but consider the potential need for a psychologist.
Right, because isn't it? It's always fascinating to me that a lot of times the misophonia patients do really well with CBT, cognitive behavioral therapy, because a lot of times their reactions are only to the people they love the most. So
Yeah.
their
Mm,
family, their spouse, their fiance. I had a patient who couldn't eat dinner with her fiance because it was only his particular, sounds, mouth sounds that drove her crazy. And I thought, well, yeah, that this is going to be hard because this is the person you're to marry and that you love. And so, yeah, that took definitely a referral to a CBT specialist who really worked with her on some of the underlying issues there. But
mhm.
it's fascinating how complex it can be, and that it's not ever simple. It's never simple, I don't think, with some of these complex cases, especially with misophonia. Um, so tell me, with your recently released books, because we keep kind of referring back to them, um, what inspired you to write these, particular the four books that you have out with Ears Gone Wrong, starting with just the tinnitus book and then going through all the way now to your hyperacusis and misophonia book? What inspired you to want to write these books?
So I've always, I mean, the best part of my job was writing. I loved writing and getting articles published, and that was just very satisfying to me. So since I've been retired for, going on 3 years now, it was my plan to write a series of books, and that's what I've been doing. I spend most of my available free time writing. And I started with the tinnitus book, which is just an overview of tinnitus, what it is, what causes it to be a problem, what can be done about it, to just make that information available to people in general. And I'm self-publishing to keep the costs down, because I could go with a publisher and the cost would triple. So I've learned how to self-publish, and all four of these books are now self-published. And then I wanted to write a book about tinnitus retraining therapy, because that's so misunderstood. And then progressive tinnitus management is really the method I believe in the most, because it's efficient, like I said. And so I wrote a book about that. And then the sound hypersensitivity disorders, I knew that we just needed a book about that. And since I'm interested in digging through the scientific literature to support anything that I write. That's what I did with this latest book, and I discovered a lot. It was a learning journey for me, and as I learned, I put that down into the book. And I think it will serve a purpose of teaching people about how these sound hypersensitive disorders are different, and how they can be diagnosed differently and how they can be treated differently. We don't have a lot of good answers for pain hyperacusis. We really don't know what to
Mhm.
do about pain hyperacusis. That's a different animal, and it's very rare. But we are now doing a monthly sound hypersensitivity disorders discussion group, like a support group online with Zoom. And most of the people that are joining that have hyperacusis, and a lot of them have pain hyperacusis. And pain hyperacusis is an extremely difficult disorder to treat. You were mentioning people just stay home. People with pain hyperacusis are locked in their houses. They're often wearing earplugs and earmuffs while they're in their homes. They are completely disabled, and I've realized what a serious disorder that is. We don't see those
Mhm.
people because they're not out in public. They're at home covering their ears. So anyway, and now I'm writing a book called Tinnitus Stepped Care, and it's kind of derived from progressive tinnitus management. And I'm actually publishing that through Plural Publishing. I'm going to have that book completely written within the next 2 months. And that will be directed to audiologists. That will be kind of an overview of a stepped care approach for how to provide tinnitus services. And then I include a chapter on sound hypersensitivity disorders. So it'll be a fairly comprehensive book.
Oh, that's great. We definitely need more. We need more uh, information like that, and like these books, and the four that you've written so far are really meant for the general public, right? So the ones that you publish under Ears Gone Wrong are really written with the patient in mind, or the person experiencing the symptoms in mind, to be able to really understand these complex topics. Is Was that your goal really in writing them, was to be able to reach more people with these symptoms that are getting misinformation out there?
That was my original goal, and that's what for my first book. That's what I said the target audience was. But then I realized that I'm digging through the literature. I'm not just expressing my opinion. I'm writing what's in the literature and referencing everything. So I'm writing it like I would write a scientific article, but I am trying to write it in a way that can be understandable by the general public, and also by
Mhm.
non-ear specialists, psychologists, and other people. So I'm trying to write to a very broad audience and trying to make sure any scientific terms are defined. The language isn't overly technical. I'm trying to make the
Mhm.
information accessible to anybody who's interested in learning more about these different topics.
Yeah, it's so helpful. It really is. And I think, you know, we have to read things in multiple ways by multiple authors for some of these complex topics to really sink in, and for us to really say, I get it. And so you know, the tinnitus retraining therapy book, this one, the second one that you wrote, I hand it to my audiologist the first day. They come to us and say, please read this, because what I also love about your books is you usually provide case studies or examples of patients with the symptoms and their pre post scenarios, so that it really does provide you with the hope that, you know, hey, look, these people got better, here's how they accomplished it, you could be like this person too. And so I think that is really impactful for not only people experiencing tinnitus, but also for audiologists that are new, or clinicians new to tinnitus, because like you said, there's a lot of misconception even in our field, I think, where there's kind of fear of, I don't know if I can help a tinnitus patient, so I'm going to avoid that area. I'm not going to really know what to do, so I'm not going to try to counsel or provide any information. But by having your books and having this deeper understanding of how you can relate and how you can help, I think we can reach a lot more people. We can help a lot more people with this knowledge. So I really appreciate your books. I'm excited. I just ordered your hyperacusis and misophonia book, because I think that one just was released recently. Am I correct?
Yeah, I think maybe 2 months ago.
Okay, great, great. Yes, I just ordered it. I think last week. I'm supposed to be receiving it this week. I ordered 3 copies because I have 2 other audiologists that also want to read it at the
Hmm.
same time.
Good.
So always exciting to get your recent books, and I'm excited for the stepped care approach. Now let's talk about the future. I've heard you mention in a previous webinar something about the Tinnitus Learning Network. Can you tell me more about what that is, and what you're hoping to achieve with something like a Tinnitus Learning Network?
Yeah, it's actually called the Tinnitus Learning Health Network. And
Ah, okay.
so the last grant proposal I wrote when I was at the VA was to do a program grant, meaning a multifaceted grant to develop what's called a practice-based research network. And that would be a network of mostly audiology clinics that work together to answer questions and to learn from each other. With a practice based research network, we would actually conduct clinical research studies to evaluate different methods, but actually to do the research in the clinics with real audiologists and real patients. And I was really excited about that idea. Well, the grant, after spending 6 months writing it and submitting it and waiting months, it got rejected. And that was the last grant proposal I wrote, and that was discouraging to me because I really believed in the concept. And then this person, Jeff Reagan, approached me, and he had this idea for a tinnitus learning health network, which is basically the same idea of getting a network of audiology clinics all working together. And there's this concept of learning health networks that's well established for all kinds of disorders and diseases. So it's not a new concept. It's not something that hasn't been done before. And I've been working with Jeff, and a group of us are trying to put together a tinnitus learning health network. We actually have an organization. It's mostly Jeff doing all the work, and we're supporting Jeff in what he's doing. But he is very devoted to this concept and trying to make it all happen. And we're having our first planning meetings coming up later this year. And we're going to really flesh out all the details of how we're going to do this. But the idea is to have a network of clinics. They're all communicating with each other. They're gathering data on their patients. They're sharing the data. The data go into a common repository and get analyzed, and we can report the data back to the clinics. The patients have input on what's going on, and it's this gradual learning network where we're all learning from each other and coming up with, well, I use this instrument, well, you use this instrument, and then you talk about, well, which one works better, and hopefully everyone's doing basically the same thing. That's where tinnitus stepped care comes in. It's a framework to provide tinnitus services, but not to specify exactly what any clinic needs to do. If they're all working within the same framework using the step care approach, they can do TRT or CBT or whatever, just fit hearing aids and do basic counseling, and it all fits within this framework. And then the important thing is that all of the clinics are using common outcome instruments so that we're assessing outcomes the same way across clinics, and we can combine those results, and then we can start looking at which patients are doing better with which treatments. It'll answer a lot of questions that right now we just really don't have any idea. So it's a concept I really believe in
Mhm.
right now.
Yeah, that sounds amazing. I'll definitely have to talk to you offline about that more. I would love to participate. We definitely have a lot of data, even within our clinic, over the past 13 years, that I'm trying to figure out how do I use this data, the
Hmm.
pre TFI, so that we use the tinnitus functional index pre, and then 6 months, 12 months, 24 months in, and I have all this data. I would love to uh, take it to the next step, and look at the data more concisely. But the Tinnitus Learning Health Network sounds like an amazing concept that could really, I think, help the whole field understand better what's working, what's not, maybe, or just like you said, maybe if there's a particular profile of a patient, this approach works better, because there's so many different profiles that we see. But as sometimes I feel like it's throwing a dart at a dartboard, and you're thinking which one's going to stick, which one's going to work. If we had that network, we wouldn't have to be throwing the dart. We could say, oh, well, based on this data, this will be most likely the right path for you to take, versus, well, let's try this, and if it doesn't work, we'll shift gears, which is what we currently do. But it can take a lot of extra time if we start with one option and then have to shift 2 or 3 times to get it right. So that would be an amazing advantage, I would think, long term.
Yeah, so
So
different patients have different needs, and they have different
yeah.
personalities and different
Oh yeah.
circumstances, and you need to take all those things into account to determine, what's the best approach with that particular patient.
Right, right. That's what we say. It's never dull, never boring, because no two people are the same, no two brains are the same, and so you have to really adapt to the individual for sure. So with kind of that standardized ideal tinnitus care model that we're kind of talking about, I'm hearing you say that the tinnitus stepped care approach might be what we're missing, what we need to really get to a more standardized model. Is that what you're thinking with the next book you're almost finished writing
Hmm.
with tinnitus step care?
Yeah, so I can go through it real quickly. Step care is
Yeah.
kind of like progressive tinnitus management, and a lot of it's really based on the concept of progressive tinnitus management. And progressive tinnitus management has 5 steps. Tinnitus step care has 6 steps. So the first step is the triage. A patient shows up in oncology and complains of tinnitus. What does the oncologist do? Well, they need to refer the patient appropriately. So step one is really
Mhm.
the referral level, the triage level. Where does a patient need to start? And the default is audiology. Most likely, if a patient has tinnitus, they also have hearing loss. They need to go to an audiologist. They need to have their hearing evaluated, and they need to do a screen for tinnitus, a screen for sound hypersensitivity disorders, and find out if they need hearing aids or not. Basically, the audiologist can figure that all out and also determine if they need to be referred to otolaryngology. Do they have something going on that would indicate some underlying cause of their tinnitus, which would be secondary tinnitus? The audiologist will know to refer or not. And then step 3, so if their tinnitus is bothersome, the next step is education. They need full education about their tinnitus. They need about an hour's worth of instruction. What is tinnitus? Why does it become a problem for some people? How does it become a problem? What can be done about it? And then that gives the patient the information they need to make an informed decision about whether to move on to the next step, which is basically tinnitus counseling. Tinnitus counseling is CBT, tinnitus retraining therapy, tinnitus activities treatment, progressive tinnitus management, or just sitting down with your patient and counseling them, maybe fitting hearing aids, some kind of devices. That's step 4. I call that the tinnitus counseling level because it's mostly counseling, it's mostly psychotherapy, talk therapy.
Hmm.
And then
Hmm.
if that's not enough, and it usually is, that's enough for most people, then they can move on to step 5, which would be a comprehensive evaluation by both an audiologist and a psychologist. What's going on with this patient, and why isn't the person making progress? With all this that has been done, they're still having trouble with their tinnitus. So let's do a complete analysis to see what's going on. And then if they need further services, then they'd move on to step 6. Now, step 6 would just open it wide open. There's bimodal stimulation, there's acupuncture, there's alternative methods, there's you name it. That would be step 6. You've done all these other things up to that point, figured out the patient still needs help, and you figure out, well, okay, what can help the patient at this point? So those are the 6 steps of tinnitus step care.
Yeah, no, it makes a lot of sense. And I think a lot of people that are doing tinnitus are maybe trying to combine some of those steps together, and it's a little messy. And I like the 6 neat steps because, like you said, for a lot of people, step 4 is enough, and you don't have to go to step 5 or 6. So it is case by case, but that really does simplify matters, make it a little bit more neat and clean. Let's follow these 6 steps in order if needed, all 6. If not, maybe just the first 4.
It's not rigid. It's a suggested
Hmm.
framework, and people can work within
Hmm.
that framework. Or some people may
Hmm.
say, "Well, this person needs treatment. We don't, the education is not necessary." They people have different opinions about all this, but basically, I'm trying to
Hmm.
create a structure that most people can use, and it would be efficient and effective for most patients.
Yeah, no, I like it. I think that could really help a lot of people out there that really kind of feel lost, or maybe they don't feel that they know how to appropriately handle the complex case of like tinnitus and hyperacusis, for instance. So I think that that could really be helpful for more people to have that framework, for sure, because there really isn't a framework that I am aware of being taught in
Mm.
our doctoral programs at all. So we need to start somewhere. And how do we change the doctoral programs? I feel like I've heard somewhere that we've been teaching audiology the same way for the past 75 years, and how do we get that to change? How do we incorporate more of what your work has shown, more of what you're writing about? How do we get that changed at the audiology schools?
So chapter one in this new book I'm working on addresses that exact question. And really the bottom line is, if the audiology students aren't learning it in their program, they're not being tested on it for their qualifying exam. And if they're not being tested on it, then the AUD programs have no incentive to teach the material. So ASHA, who oversees the certification process for audiologists, and the praxis tests that audiologists have to take to qualify to become an audiologist, those standards need to change. And I've made specific suggestions for there's ASHA. It's an outline of what information needs to be taught in AUD programs, and I've actually made specific suggestions for what should be taught relative to tinnitus and sound hypersensitivity disorders. And then some questions could be included in the qualifying exam, and then that would hold
Mm,
every AUD program accountable to make sure they teach this information, because the students may get tested on that information. And if they're not tested, they
right.
know they're not going to be tested. They have no incentive to do the teaching. So that's basically my approach, and I've
Ah,
written that all
okay.
up. And I don't know if it'll make a difference or not, but that's my suggestion.
No, that makes a lot of sense. I didn't think of it from that perspective. But of course, if we're not being tested on it, what incentive do they have to teach it? So it
Right.
starts there with
And it
yeah,
wouldn't be
having
fair to
incorporated.
ask a
Yeah.
lot of questions about tinnitus if the programs aren't required to teach the information. So it goes back to, you've got to change the standards for
Yep.
what is supposed to be taught in these programs.
Yeah, yeah, no, because thinking back in my program, I picked tinnitus. I was fortunate that I could pick tinnitus as my elective at Sallius University, and Margaret and Paul Yastreboff, Dr.
Mm,
Yastreboff, taught the course. I mean, how lucky was I?
hmm.
But that wasn't something that was required. I just had an interest in it, and that's why I picked it as an elective. So you're right. That does need to change. I'm looking forward to reading that chapter in your book about it. That would be really helpful. And so, kind of last two questions to sum up our discussion here today, Dr. Henry. I know many of our listeners are either struggling with tinnitus themselves or maybe have a loved one who is. And what would your advice be to someone just starting the journey with tinnitus or sound sensitivity, and they're probably feeling a bit overwhelmed by everything in the beginning? What advice would you give someone who's new to this arena of tinnitus or sound sensitivity?
I think the main thing is that they need to know that there are good treatments available. We can't eliminate the sound, but we may be able to reduce the sound if we can turn down the volume of the brain. We can't prove that. We can't guarantee it. But the main thing is to know that the problem with tinnitus is not the sound itself. I mean, I have the sound; it's in my ears all the time. I don't like it. I wish it wasn't there, but my life is completely normal in spite of my tinnitus. So that's the whole concept of treatment, is habituation. get the point people to the point where they're not paying attention to their tinnitus most of the time, and when they do pay attention to it, they're not reacting to it. It's just, oh, there it is. And that's the point that I'm at. I'm fully habituated to my tinnitus. I hate it. I don't like it. I wish it wasn't there, but I'm fully habituated to it. And so that's the goal for patients. And these treatments we've been talking about, any one of them, if conducted properly by an audiologist, maybe a psychologist who really knows what they're doing, can get the person to the point of habituating to their tinnitus. So that's the main thing, is just having that knowledge that these methods are generally effective for most people. It takes some work, takes some effort. It's not taking a pill and getting better. It's
Right.
putting in the work, putting in the effort, working with somebody who knows what they're doing. Hearing aids might be helpful. Sound therapy is generally helpful, and just becoming aware of all these things and following through and getting the proper guidance and direction. And most people will habituate to their tinnitus.
Right. And I used to always really love to think of Yastroboff's model and we have to block those reactions, the nervous system's reactions, before we'll ever be able to block any perception of it. But would you say there are times when you are able to block your perception of it? So is that fair to say, habituate, for someone who has fully habituated, there are times when they can block their perception of it, even though it's still there in the background? Do you agree with that?
I think it's an automatic. He calls it conditioned responses. We condition our brain to stop paying attention to the tinnitus. That's the whole point of TRT, is
Hmm.
to
Hmm.
facilitate that process. And if you're not aware of it, it's not there. If you are
Right.
aware of it, it's there. But like for me,
Mhm.
even as loud as it is, I have very loud tinnitus. I'm not aware of it most of the time. So
Mhm.
effectively, I don't have tinnitus most of the time. And then when I'm
Mhm.
talking about it, like right now, I'm very aware of it. Oh,
Yeah.
now I'm thinking about it, but I'm not,
Right.
it's not affecting me. And then I can move on with my life. And TRT is really good at explaining the underlying principles, what's going on in the brain that it causes us to react to our tinnitus. What are the areas of the brain that are involved, and how do we habituate, and what does that mean inside the brain? That's the neurophysiological model that you mentioned, and that's a very powerful counseling tool.
Yes. Yeah, it is. It's complex, but it is very
Yeah, it
powerful when
is.
you can break it down and understand it, for sure. And yeah, finally, for audiologists or clinicians just starting to work with tinnitus, what would be your best piece of advice for them, for new audiologists to working with tinnitus?
I'd say, learn all you can. Some audiologists are more interested in tinnitus than others, like you were.
Hmm.
I
Hmm.
landed in this lab, which got me interested. But learn all you can. There's a lot of books, there's seminars, there's training courses. There's a lot available. But an audiologist, has to be self motivated to learn the information. But the information is out there. There's plenty of
Yeah.
information. It just takes effort to learn it, and also to be motivated to help patients. I'm sure every audiologist has
Hmm.
patients coming in complaining of tinnitus and
Hmm.
hyperacusis and maybe misophonia,
Hmm.
and audiologists are in the perfect position to help those people. And it's not
Yeah.
that difficult to
Right. Right.
learn what you need to learn to really provide good help to these people.
I agree. I agree. And one last question, because I just thought of it, because I know I'll have somebody ask me this. When you're writing, so I've had tinnitus patients where they were authors or avid readers, and they come into the clinic and say, you know what, I can't write anymore. I can't read anymore because I have no peace and quiet. I cannot focus. I have to read the same page multiple times because I feel like my tinnitus is dominating my thoughts and I can't comprehend the material I'm trying to read or trying to write. Do you have to use any sound therapy while you're writing, Dr. Henry, to stay focused, or what are your strategies to
I
help
do,
there?
because sometimes I'm sitting in quiet and I'm writing and my tinnitus is
Hmm.
so loud, it's pretty hard to ignore. It is distracting. So
Hmm.
I use sound therapy almost all the time that I'm writing, and I use my smartphone. I have
Hmm.
earbuds in my ears,
Hmm.
and my favorite is Baroque music. Baroque music is just the
Yeah.
perfect music or the perfect sound therapy for me when I'm concentrating, when I'm reading, and
Hmm.
especially Baroque organ music. I just love it, and I'm playing it
Hmm.
the whole time I'm writing, and it just takes my mind in the right place. It
Hmm.
gets my mind off of my tinnitus and helps me to just focus on my writing. And I think it's different for
Hmm.
everybody. You know, we all have
Yeah.
different preferences in music, but I like music that it doesn't have words. Now the words would just
Hmm.
be distracting, so it has to be
Hmm.
instrumental music, and it has to be soothing music, and it can't be too
Hmm.
upbeat. Rock and roll doesn't work for me. Or I love the
Yeah.
Beatles, but I could never listen to the
Hmm.
Beatles and be writing. So
At the same time.
I definitely use sound therapy, and I use sound therapy all night long. I use sound therapy all day, all night long, even though I'm fully habituated to my tinnitus, because I prefer not to pay attention to my tinnitus.
Yeah, me too. Me too. I have tinnitus in my left ear. I've been
Mm,
listening to Rain at night for over 20 years now, and I couldn't sleep without my Rain
mm,
app on my phone playing all night
mhm.
long.
Yeah,
Even when my tinnitus isn't super bothersome now, it just is something that soothes, calms, and distracts. So, yeah,
exactly,
I was
exactly.
curious about that. But yeah, the Baroque music, I could see why you like that. I think that was track two, honestly, on the Neuromonics device
Mm,
back in the day. I used
I
to
think it
describe
was,
it to
yeah.
patients as track two sounds like Baroque music. So if you
Hmm.
like that, you'll like track two. But you're right, finding something soothing, calming without the lyrics for sure
Hmm.
could be a great way to be able to read and write more effectively with tinnitus in the background. So, well, Dr. Henry, it's been an absolute honor having you with us today. Your work has honestly brought clarity to a very complex space, and more importantly, hope to a lot of people struggling in silence. And so for those of you listening, check out the show notes for links to Dr. Henry's books, his website, and other links to information that we talked about today. And as always, if you found this episode helpful, please share it with a friend or a loved one who experiences tinnitus. Leave us a review and don't forget to subscribe as well. Until next time, remember you are not alone and keep listening. Thank you.